university teacher. I teach nurses, delivery assistants, social workers, and so on. My co-author Luděk is demographer. He works in a health insurance company. And the co-worker is also doctor, medical doctor. I will show some pictures from him to you. The last century brought to us the need to build medicine on a scientific basis. We would like to avoid mistakes, bad practice, uncertainties, and wastage of money too. The philosophy gained the name evidence-based medicine. And as the nursing is a very important part, maybe essential part of medicine, the evidence-based nursing was also established. With creating discipline as a scientific, it needs scientific language. So there was the need to create standardized nursing language. The expected benefits of that was this better communication among nurses and other healthcare providers, increased visibility of nursing work, improved patient care and better data collection for research, and so on. Many attempts to create standardized language for nurses was here, and many attempts to create standardized nursing classification was here. The newest taxonomies are these. First, NADA International Nursing Diagnosis, Nursing Interventions Classifications, and Nursing Outcomes Classifications. This is a big project from Iowa University. These taxonomies were translated to many languages. They tell about these taxonomies that they are comprehensive, research-based, standardized, and as another important benefit, there is written in studies that they are patient-centered or individualized or holistic, and so, because they contain domains related to psychosocial context, and it is assumed as important as physical context. As I teach nurses, I have found that what is taught at my university, and I wanted to look better at what it is. I and my colleagues, we have many considerations about that taxonomies. A few of our consideration I would like to share with you. The first and maybe most important is language problem. The taxonomies are created with the philosophy that we have some words that are clear, that are sure, and that are basic. And with these words we can create more complicated concepts, and with the more complicated concepts we can build ever more complicated concepts. But this philosophy don't take in account the vagueness of the language, the fuzzy that the language is very extremely dependent on the context, like this philosopher says. I would like to show you how it looks like, the taxonomies. This is one page of the nursing intervention system. You can see domains, categories, and the names of interventions with codes. It looks like here, for example, category coping assistance contains these interventions. And as you can see, the language, it doesn't look like the simplest words explaining the more complex concepts. Coping assistance is quite good name for some activities, but hope inspiration as a subcategory of coping assistance, and maybe better describable, or hope inspiration humor mood management. I think it is not good. I would like to show you one of the interventions. It has always name, the code, the definition, and the activities needed to do this intervention. And again, you can see the very complex, difficult, vague words in the explanation of the name of the interventions. So it was our first and most important concern about the NIC and OC and non-diagnosis. The second is translation problem. These classifications are translated to other languages. For example, to Czech language, you can see that Czech Republic is always late in the translation. And it is another problem because another language has another context. And for example, the evidence-based medicine and evidence-based nursing was translated to Czech as proof-based medicine and proof-based nursing. It is quite different translation with quite different explanation and context, because proof is something like then Sherlock Holmes tell this is the murder, but evidence is a paper with result of research. It is quite completely different. Our consideration with this classification is competence problem, because nurses identify psychiatric diagnosis like this, for example. But for this diagnosis in my country is very high education needed. Magister or doctor study in psychology or psychiatry, and then many courses and certificates in psychodiagnosis. I have PhD in clinical psychology, but I can't do this diagnosis because I don't have the certificates for psychodiagnosis. So I think it's very problematic. Our consideration, the nurse writing down all the codes, it is hundreds of thousands of codes in one day. For any nurse has no time to deal with the patient. There is no time for direct care, because only care with papers is done. Some studies tell that only 1/3 of nurse workday is spent with the patient. Another problem is the staffing, because the population is aging. There will be much more patient and much less nurses where we find the person for caring. And another problem is the problem of complexity. There will be extreme numbers of codes in the documentation, and who will be oriented in this, how we will do diagnosis and prognosis and therapy for the patient. So we think that the total algorithmization, total categorization, total formalization of the work of nurses and doctors is not possible. Then work is too much formalized. It destroys space for freedom decision. And if doctor and nurse has no freedom for decision, there is no responsibility for his work. And it is bad, it can bring nothing good, we think. So in our conclusion is that this taxonomy don't fulfill the benefits they promise to bring. So I am ending with my a bit skeptic presentation, and thank you for your understanding.